Welcome, everyone. In this clinical update, we're going to get straight to the point. A practical, subgroup-driven approach to myasthenia gravis that you can actually use in your practice.
So let's get right to the heart of it. The big question in managing MG today is this: how do we move beyond just looking at a positive antibody test? It's really about understanding that myasthenia gravis isn't one single disease. It's a collection of distinct subgroups, and recognizing that is the absolute key to unlocking more personalized and, frankly, more effective treatments.
Everything, and I mean everything, starts right here. Getting your patient's management plan right hinges on correctly classifying their disease subtype from the get-go. This is the foundation that guides your entire diagnostic and therapeutic strategy.
Now, these aren't just some academic labels on a chart. You have to think of each subgroup as its own distinct entity. They have different underlying mechanisms, and that explains why they present so differently, and more importantly, why they respond so differently to our treatments. For instance, you see thymic problems all the time in acetylcholine receptor or AChR positive disease, but it's pretty much absent in muscle-specific kinase or MuSK-MG. Big difference.
Okay, so you look at this and you think, right, ACNR positive is the big one, about 80%. And you're right, it is. But that means up to 1 in 5 of your patients will fall into these other buckets, the MuSK positive or seronegative groups. And managing them correctly requires a completely different playbook.
All right, let's take this out of the textbook and into the clinic. How does this all translate into a smart, efficient workup? We're going to cover some really high-yield tests and a logical algorithm to follow.
Never underestimate the power of a good bedside exam. For a patient who comes in with ptosis, the ice pack test is still an incredibly valuable tool. It's simple, right? You place an ice pack over the eye for a few minutes, and if you see that eyelid lift by more than 2 millimeters, that is highly suggestive of MG. Super useful. And here's another classic sign to keep in your back pocket. Kogan's lid twitch. You just have the patient look down, then quickly back to a central gaze. If you see that brief little twitch of the upper lid as it overshoots, that has excellent specificity for MG. It's especially helpful in those purely ocular presentations. For your serology, a stepwise approach is always the most efficient and cost-effective. Always start with AChR antibodies. If that comes back negative, your next move is to reflex to MuSK. If both of those are negative, you're now dealing with a seronegative patient, and that's when you start thinking about LRP4 testing or even more specialized cell-based assays that can sometimes pick up those tricky, low-affinity AChR antibodies that the standard tests miss.
Neurophysiology becomes absolutely essential when your antibody tests are coming back negative. Repetitive nerve stimulation, or RNS, is a good place to start. But listen, a normal result does not rule out MG. For those seronegative cases, single-fiber EMG is really your go-to. It's way more sensitive for detecting that dysfunction at the neuromuscular junction, even if it is a bit less specific.
Okay, so you've done the workup, you've classified the patient. Now for the payoff. That autoantibody profile you found, it's going to directly dictate your entire therapeutic strategy. And just look at this. The differences in management are stark. It's night and day. Take pyridostigmine, a cornerstone therapy for AChR patients. In MuSK patients, it's often totally ineffective and can even make their symptoms worse. Same goes for thymectomy, indicated for AChR-MG but not for MuSK. And rituximab? It works so well on MuSK-MG that many consider it a second-line therapy, not just something you save for refractory cases. This really drives the point home. The indication for thymectomy is very specific. You do it for patients with a thymoma, period. And you consider it for many of your non-thymoma patients who are AChR antibody positive, especially those who have early onset disease. But what about those tougher cases? The 10 to 30% of patients who just don't respond to our conventional therapies. Well, this is where a whole new wave of targeted treatments is completely changing the game. So we've already mentioned rituximab from MuSK-MG, but it's also a go-to for refractory disease in other subgroups. What's it doing? By targeting CD20, it depletes the B cells. It basically goes after the source, the factories that are pumping out these autoantibodies in the first place. It's a much more fundamental approach to immunomodulation.
Now, for our refractory AChR-positive patients, we now have complement inhibitors like eculizumab. And this is so elegant. We know that AChR antibodies do a lot of their damage by activating the complement system. So these drugs just step in and block that terminal pathway at C5. It stops the formation of the membrane attack complex right in its tracks, preventing that damage to the postsynaptic membrane.
And then there's one of the most exciting new classes, the FcRn antagonists. So think of the FcRn receptor as a recycling program that normally protects IgG antibodies from being broken down. Well, what if you block that receptor? These drugs do exactly that. They cause a rapid, widespread clearance of all IgG from the circulation, including, of course, the pathogenic autoantibodies, and that leads to really fast clinical improvement.
All right, let's bring this all home. Let's wrap up with a quick clinical checklist of the most important, actionable points from this whole update.
Okay, here's your cheat sheet. Number 1, classify every single patient by their antibody status. This guides everything. 2, use that stepwise testing algorithm, AChR first, then MuSK. 3, tailor your initial therapy. Remember, be cautious with paridostigmine and avoid thymectomy and MuSK-MG. 4, consider rituximab early for those MuSK patients. 5, know your new options. Complement and FcRn inhibitors for tough refractory cases. And finally, don't forget the non-pharma stuff. Tailored physical exercise can make a real difference in strength and outcomes.
And all of this brings us to one final thought. When you think about it, with therapies that can block complement or wipe out B cells or rapidly clear antibodies, we're moving so far beyond just broad immunosuppression. So the question is, are we on the cusp of an era of truly precise, personalized immune modulation for myasthenia gravis? It's an exciting time.